Hi, everybody. Dr. Becker. We are on chapter 80, which is our non-HIV antiviral drugs. Chapter 80. These are basically, we're talking about herpes simplex virus, varicella zoster, which is your chickenpox and shingles, viral hepatitis and influenza, and some of the others. But specifically, these are not ones that are involved with HIV. This chapter I do think is a little different in that Laney's doesn't really go into as much as the physiology review as they have in other texts. They just kind of jump right into treatment. The first thing they start talking about is the herpes simplex virus, which is HSV, and the varicella zoster virus, which is VZV, and kind of how they work with treatment for the antivirals. The concepts here for the antiviral therapy is that our ability to actually treat viral infections remains quite limited. What we think we can achieve is that when we give antivirals, we slow replication of the virus down. So maybe the duration of symptoms is less or help it go away. But it's not the same as what we talk about when we think of antibiotic therapy of trying to be like bactericidal. It's not quite the same. The viruses use the biochemical machinery of us as host cells to reproduce. So that's really tricky to identify drugs that are only going to work on the virus. And it's difficult to suppress viral replication without doing us harm as well. So they're just difficult to treat. The antivirals suppress the biochemical processes unique to viral reproduction. Okay. So kind of starting off here with the herpes simplex and the varicella. The first drug they talk about that helps treat these conditions is acyclovir. It is one of the oldest antivirals we have and still one of the most used antivirals. It is the agent of first choice for most of the infections for herpes simplex and varicella zoster. It can be administered topically, orally, or intravenously, and it's pretty well tolerated with pretty minimal side effect. It's the only, it is active only against members of the herpes family, which does include the HSV, varicella zoster, and the cytomegalovirus. So of those three, the most sensitive to acyclovir is the herpes simplex. Second most sensitive is the varicella zoster, and the third most sensitive is CMV. In fact, some strains are resistant now to acyclovir. So really, they work pretty darn well, though, for herpes simplex and varicella zoster. Your book talks about the way that the mechanism of action works for acyclovir. It inhibits the viral replication by suppressing the synthesis of viral DNA. To exert antiviral effects, acyclovir must first undergo activation. The critical step in activation is the conversion of acyclovir to acycloguanosine monophosphate, which is GMP. And that happens by thymidine kinase. So when it's formed, the acyclo-GMP is converted to acycloguanosine triphosphate, which is GTP, the compound that is directly responsible for inhibiting DNA synthesis. So there's kind of these different steps that have to happen for the mechanism of action to get the effect that we need for the acyclovir. Once you get down to the acyclo-GTP, that is what suppresses DNA synthesis by inhibiting the viral DNA polymerase and becoming incorporated into the growing strand of the viral DNA, which then blocks further strand growth. So what I'd like for you guys to realize is that there's a couple of steps that have to happen in the body for acyclovir to work. It has to be activated through the process of converting to acyclovir, converts to the GMP by the thymidine kinase. Then that is converted to GTP And this GTP is what suppresses the DNA synthesis and ultimately blocks it reproducing and growing. The herpes viruses do develop resistance to acyclovir through 3 ways, and those are listed in your book. I don't expect you to memorize these 3 ways by any stretch of the imagination, but I want you to understand that we do get resistance to acyclovir because we know that just like bacteria, viruses can be pretty smart and start to adapt to become resistant to our treatments. Of the ways that resistance happens, thymidine kinase deficiency is the most common. So, important point that I want to make about the resistance is that resistance is pretty rare actually in immunocompetent patients. So, outside of HIV, outside of severe sepsis, outside of like neutropenia, most of acyclovir to the herpes simplex virus and the varicella zosters works pretty well. You have to start considering that maybe you're going to run into that thymidine kinase deficiency in immunocompromised patients. The other people is transplant patients, right, that are on immune suppressants. So with that being said, if you have lesions that are caused by resistant herpes simplex virus, they can be quite extensive, they can be severe, they can be very debilitating, and then can also be resistant to the acyclovir. So something to think about that when we think about acyclovir, it works the best in herpes simplex, it works the next best in varicella zoster. Sometimes it works for the cytomegalovirus, but a lot of times it's resistant to that. In order for the acyclovir to work, it has to be broken, it has to be activated, and that activation goes from the acyclovir to the GMP by thymidine kinase. The GMP then becomes activated to the GTP, and that is ultimately what suppresses the DNA synthesis and prevents it from replicating. But because of that need to go through those steps, sometimes in immunocompetent patients, they don't have thymidine in enough abundance to actually break down the acyclovir, and so you can get resistance. We use acyclovir quite a bit. Oh, sorry, hit the wrong slide. We do use it quite a bit. You're going to see it in practice. You've probably seen it quite a bit as a nurse. We use them for mucocutaneous herpes simplex infections. Very common. So you're going to see herpes infections at the face or the mouth or throat, and those are typically caused by HSV type 2. So HSV 2. For immunocompetent patients, meaning we have a good immune system, oral acyclovir can be used to treat these infections of your gums, your mouth, your lips. You can also take oral acyclovir prophylactically to prevent episodes of recurrent herpes labialis, which is the name for the common cold sore that we get on our lips. That's a herpes infection. The tricky part about that is there's truly no effective way to get rid of herpes labialis or from it coming back. Mucocutaneous herpes infections can be especially severe in immunocompromised patients, which makes sense. Sometimes they are the ones that end up needing IV acyclovir. So we use acyclovir for the mucocutaneous herpes simplex infections. We also can use acyclovir, like we said, for the varicella zoster. Higher doses of oral acyclovir are typically effective for shingles in older adults. Oral therapy is also effective for chickenpox in children, adolescents, and adults, providing that the dose is begun within 24 hours of the rash onset. Very important point to know, if you're treating chickenpox in adults, really, if you don't start the acyclovir very soon, like within 24 hours of first seeing the rash, you're probably not going to get a lot of effect from taking the acyclovir. IV acyclovir is the treatment of choice for varicella zoster if they're immunocompromised. So if you have a neutropenic patient, an AIDS patient, and they have a herpes outbreak or a chickenpox or shingles outbreak, you're probably going to use IV acyclovir. The next thing we use it for is herpes simplex genitalis, so genital herpes, and we will discuss that more and when we get into the next chapters in the sexually transmitted diseases. Pharmacokinetics. The acyclovir may be administered topically, orally, and IV. So that's really what I'd like for you to know. Also, no significant absorption will occur when you apply it topically. The other component to know is there is a renal component, because with normal kidneys, your half-life's about 2.5 hours, but it will become prolonged by renal impairment. And if you're not making any urine or you have severe kidney disease, it can last in your system for 20 hours. Table in your book, it is table 80.1, which does a nice breakdown of all the different drugs and what they can be used to treat. And then table 80.2 talks a little bit about that pharmacokinetics as well, which would be a good reference in practice, etc. Okay, so as we always do, we've talked about mechanism of action, indications for use, how it works. Now let's talk about our adverse effects. It is, when you're giving it orally, it really has a pretty good profile for adverse effects. The most common could be nausea, vomiting, diarrhea, headache, or vertigo. Topical acyclovir can cause kind of a transient burning or stinging, but systemic reactions do not occur. Good news is it's also safe to use in pregnancy, so it can be used to suppress recurrent genital herpes near term. So that is an important part when you get into talking about caring for the pregnant mother. This will come up probably further down your program, in your decision-making courses. That if a female is pregnant and getting near term and she has an active case of herpes genitalis, and you're planning on a vaginal delivery, they will oftentimes go ahead and treat that with the acyclovir, and it can be safe to use in pregnancy. You can also have effects from the IV form because it can cause renal failure. So you have to be careful and monitor IV acyclovir and their renal function. They may need more aggressive hydration. The big thing about these treatments, these antivirals, is we have to educate our patients that they only decrease symptoms. It doesn't actually eliminate the virus, and it doesn't actually cure it or treat it. Table 80.3 gives you a nice drug preparation dosage and special considerations for some of these drugs as well. It does mention in here specifically with IV acyclovir, this is table 80.3, it does specifically address that to decrease the risk for renal injury and neurologic toxicity, you should ensure adequate hydration before beginning IV therapy with acyclovir. Next drug that we talk a little bit about is, excuse me, valacyclovir, which is a newer version of this drug that's been out now for a while. A lot of people like to use valacyclovir. I know that it's more expensive typically for the patient than acyclovir. It is the prodrug of acyclovir, so it's a little different. When you give acyclovir orally, its bioavailability is about 15 to 30%, but when you give valacyclovir orally, the effective bioavailability is greatly increased when it becomes acyclovir to 55%. So therefore, when you give valacyclovir, you're going to get a more efficient way of getting acyclovir into the body. So valacyclovir is approved for the management of herpes labialis, chickenpox, shingles, herpes simplex genitalius, or genital herpes. Okay, so you will often see it for the herpes of the lips and the genital herpes a lot. It's also a choice that you could use for chickenpox and shingles. Off-label, people are using the valacyclovir for prophylaxis for some patients with cancer. They talk about the adverse effects with valacyclovir, and they note in your book that when they used valacyclovir in immunocompromised patients, so people with a poor immune system, they developed sometimes a syndrome known as TTP/HUS. So that is thrombotic thrombocytopenic purpura hemolytic uremic syndrome. TTP-HUS. So that has been associated in the literature with valacyclovir. That's a big deal because that syndrome can be fatal. As far as they know, it's never happened in an immunocompetent patient. So the FDA has not approved the use of valacyclovir in immunocompromised patients as of this publication, with the exception of chronic suppressive therapy for recurrent genital herpes in patients with HIV. But with that being said, there are more and more reasons that they're trying to use valacyclovir again in immunocompromised patients. But because this TTP-HUS did occur, it was always in doses greater than 8 grams per day. So if people are using it, they're making sure to stick to less than 8 grams. So that is something to consider if you did deal with an immunocompromised patient, an AIDS patient, a severely neutropenic cancer patient, a transplant patient. If you're going to use valacyclovir, you have to consider the TTP-HUS as a possibility. Next drug they talk a little bit about is the famciclovir, and that is the prodrug of penciclovir. The famciclovir undergoes conversion to penciclovir, its active form. The penciclovir then undergoes intracellular conversion to penciclovir triphosphate, which is a compound that inhibits the viral DNA polymerase and thereby prevents replication of the viral DNA. So under certain conditions, the formation of penciclovir triphosphate requires viral thymidine kinase. Famciclovir is approved for the treatment of herpes zoster and herpes genitalis. If you have a patient with herpes zoster, which is shingles, the drug can decrease the time to full crusting from 7 days down to 5. Famciclovir does not decrease the incidence of post-herpetic neuralgia, but can decrease its duration. So when people were on the famciclovir and they had that post-herpetic neuralgia pain, it oftentimes could be up to 120 days. And when they saw when you use famciclovir, it could be decreased down to 61 days. So there is argument to say that maybe famciclovir or penciclovir would be a better choice for shingles. Very well tolerated is the famciclovir, but it could also cause renal failure if you don't dose appropriately. Next drug they go on to is talking about the topical drugs for herpes labialis. We're talking about the mouth sores. 2 of these drugs then are penciclovir and docosanol, and then also acyclovir we already talked about. So penciclovir and docosanol are these drugs we're talking about for topical treatment of herpes labialis. The penciclovir cream is a topical drug indicated for recurrent herpes labialis, an infection caused by either HSV2 or HSV1, even though it seems like HSV2 is more common. The drug suppresses viral replication by inhibiting DNA polymerase, the enzyme that makes the DNA. So penciclovir as a cream is supplied as a 1% cream to be applied every 2 hours except when sleeping for 4 days, which is kind of an intense dosing. In the clinical trials, the benefits were modest. The average time to healing and duration of pain were decreased by just half a day. So I'm not sure that it's worth necessarily always giving, but if you had somebody who was bound and determined to get some kind of treatment, you could consider that. The only common adverse effect was some erythema where you put it on. Docosanol cream is Abreva, and that's the topical preparation for recurrent herpes labialis. It's available over the counter as a 10% cream. So we do have some options for over-the-counter treatment of herpes labialis, which is Abreva, which is docosanol cream. It's a 10% cream. Applications done 5 times a day, beginning at the first sign of recurrence. The benefits are also pretty modest. In one trial, the treatment reduced the time to healing from 4.8 days down to 4.1. So it's about the same time as the penciclovir cream, but people tolerate it really well, which is why it can be given over the counter. It does work differently and has a broader antiviral spectrum because it actually blocks the viral entry into host cells. It doesn't kill the virus and it doesn't prevent them from binding. but because it doesn't actually affect replication, it's unlikely to promote resistance. Next thing is ocular herpes. Now, I don't know if anybody has seen or known of somebody or cared for somebody with ocular herpes. Just throwing it out there, this is no joke. This is a really hard and really painful and potentially very dangerous condition. So people actually get herpes that goes into their eye. So the first drug they talk about is this trifluridine ophthalmic solution, which is Viroptic. Again, I know we always talk about we need to use their regular names and not their trade names, but I've always known it as Viroptic. It's indicated only for topical treatment of ocular infections caused by the HSV1 or 2. It is given to treat acute keratoconjunctivitis and recurrent epithelial keratitis. The antiviral actions from the inhibition of the DNA synthesis. But, right, so it sounds great. We have a drug to give to treat that infection in our eye. However, the most common side effects are localized burning and stinging. It is not an easy drug to take. Edema of the eyelid occurs in about 3% of the patients. Systemic absorption is minimal after that topical administration, so we don't get a lot of systemic toxicity. This is one of those drugs that you tell people you have to grit your teeth and take. It's very important to take. We have to treat this, but it probably is painful and doesn't feel good. Next topical drug for ocular herpes is the Ganciclovir ophthalmic gel, which is Zirgan. It's indicated for acute herpetic keratitis, which is the inflammation and ulceration of the cornea by the herpes simplex virus. This also can cause eye irritation, red eyes, and some blurred vision, but it doesn't tend to be quite as painful as the trifluridine, the Viroptic, but those are two of the drugs you may see. In your book, it also throws in there the summary of key prescribing considerations for HSV varicella infections. And I did want to point out there that baseline kind of data to follow is the liver enzymes for both acyclovir and valacyclovir, because you can have some elevation of that. You also would want to have baseline, obviously data for their CBC and what their creatinine is. They say acyclovir, you should monitor the urinalysis to monitor for specific urine gravity to make sure you catch dehydration, as well as the valacyclovir and monitoring renal function. The next set is drugs that we would use to treat cytomegalovirus, which is oftentimes abbreviated as CMV. Cytomegalovirus CMV is a member of the herpes family, so it does include the HSV1 and 2, and also part of the herpes family is also the Epstein-Barr virus, which causes mono. CMV occurs from person to person through direct contact with saliva, urine, blood, tears, breast milk, semen, or some kind of body fluid. Infections can also be acquired by the way of blood transfusion or organ transplantation. It's actually fairly common. Between 50 and 85% of Americans 40 years or older actually harbor the virus. After your initial infection, which typically causes minimal symptoms if you're a healthy adult, the virus will remain dormant within your cells for life without causing detectable injury or illness. So for most of us, most healthy adults, CMV infection is of little concern. However, that changes drastically if you become immunocompromised. So if you have HIV, if you're cancer and on chemo, or you're on immunosuppressive high-dose drugs, you are at high risk for serious morbidity and even death, both from your initial CMV infection or from reactivation of dormant CMV. Common sites for infection are lungs, eyes, and the GI tract. Among people with AIDS, CMV retinitis is the principal reason for blindness and loss of vision. When you're thinking forward into like board certification and test exams, the really big thing about CMV is that you're going to see questions about it, and what you're going to have to know is that it can be dormant and totally of no concern to a healthy person. But if you're thinking AIDS or HIV, think CMV. It's something that's very common in a board question to have those two linked, that you would need to be thinking about CMV and what we're going to do about that. And the loss of vision with AIDS patients with CMV is one of those key components that are typical kind of board questions. So if we're treating CMV, the first drug they talk about is the ganciclovir. It's the drug that we're using against CMV. It can cause serious adverse effects, especially granulocytopenia and thrombocytopenia. So it should only be used for the prevention or treatment of CMV in the immunocompromised host. It again is converted to an active form, which is called ganciclovir triphosphate inside the effective cell. It does suppress the replication of the viral DNA, and it can cause premature chain termination, so it prevents replication. It is only approved to treat and prevent CMV infections in immunocompromised patients, including transplant patients and those with HIV or people on strong immunosuppressive drugs. If you have experience in the world of like transplant, the experience in the world of HIV/AIDS, you probably have seen some kind of cyclovir drug given to these patients for prophylactic treatment of CMV. It goes on to talk about in AIDS patients that you are probably going to be on some kind of cyclovir maintenance therapy because they relapse frequently, and that's how they lose their vision. If somebody is on ganciclovir, an important point is to advise against becoming pregnant, and the possibility for men, they have to understand that this drug could also cause sterility. So it is not a drug we use all the time, and has to be given to the right patient for the right indication, and you really have to be good about making sure that these are points of education for your patient. So you have to monitor their CBC and monitor for those things, and they should know that they're at risk for low blood counts and the possible signs of that, like weakness, pallor, fever, infections, if they're bruising frequently, breaking on the petechiae, those kind of things. Adverse effects, then again, it goes into talking about the granulocytopenia and thrombocytopenia, and the effect is the bone marrow suppression. And so people can get really even sicker now from the treatment just as much as they could from the CMV infection itself. It's usually reversible, and it usually happens more with IV therapy than with the oral therapy. The hematologic response often will be exacerbated if it's given concurrently with zidovudine. However, granulocytopenia can be reduced with granulocyte colony stimulating factors. So like Neupogen, those drugs that people can get subcutaneously to stimulate the bone marrow to make new neutrophils. Because of the risk for adverse effects of the hematologic effects, the blood counts must be monitored. And then they give you parameters of knowing that you would have to stop the drug if someone goes into those parameters. I'm not going to ask you what those parameters are. I want you to understand that ganciclovir has a space to be used to prevent and treat CMV infection. However, they should not get pregnant. It can cause sterility, and it can cause this bone marrow suppression. It's worse when you give it IV versus oral, and there's certain parameters on how to give that drug, and that it therefore has the black box warning with that stuff, which is it can be teratogenic, carcinogenic, inhibit sperm formation, and cause the bone marrow suppression. It goes on to talk about sterility for men. could be reversible with low doses, but it's often irreversible if they're having to give high doses. It can cause female infertility as well. It could cause nausea, fever, rash, anemia, liver dysfunction, or confusion as well. The valganciclovir is the prodrug of ganciclovir, so that is nice. They use valacyclovir and valganciclovir, which is kind of nice. It's the prodrug version, but it has the greater advantage of oral bioavailability over the ganciclovir. So after absorption from your GI tract, valganciclovir is rapidly metabolized into the ganciclovir, its active form. So that's oftentimes meaning you're going to have greater bioavailability. And it's huge. When you give the bioavailability of ganciclovir is 9%, bioavailability of valganciclovir is 60%. So you use the valganciclovir again for CMV treatments, such as to treat CMV retinitis or to prevent CMV disease in high-risk organ transplant patients. The adverse effects are similar to ganciclovir, and it can again be that bone marrow suppression. It also, however, can cause nausea, diarrhea, vomiting, headache, and it's presumed to have all the same black box warnings as ganciclovir. Next one is cidofovir. Cidofovir is an IV drug with just one indication, CMV retinitis in patients with AIDS who have failed to respond to the other drugs. Cidofovir is always administered with probenecid, a drug that competes with cidofovir for renal tubular secretion and thereby delays elimination. So as a result, cidofovir has a prolonged intracellular half-life and a long interval can separate doses. So you can give it just every 2 weeks. Compared with IV foscarnet, cidofovir has the distinct advantage of needing fewer infusions, which is nice. It carries a black box warning that it can cause severe renal impairments and can cause the neutropenia and can also have those sterility concerns as well. It only has the one indication for use because we don't know and haven't studied if it works well for anything else. It has the potential to cause the renal failure, which is huge. In fact, dialysis has been required after only 1 or 2 doses. So again, it's not a drug to be given lightly. Next one is the foscarnet, which is an IV drug against all known herpes viruses, including CMV, HSV, and VZV. Compared to ganciclovir, foscarnet is more difficult to administer, less well tolerated, and much more expensive. Nice, right? Like that's a drug we really want to give. However, it has its place, especially if you're into infectious disease, you'd be seeing these kind of drugs probably. Foscarnet is an analog of the pyrophosphate, which inhibits the viral DNA polymerases and reverse transcriptases, and thereby inhibits the synthesis of viral nucleic acid. What I want you to know is that it is a drug that could be used to treat all the versions of the HSV, CMV, or VZV, but it's much more difficult to administer, less well tolerated, and more expensive. It can be used for retinitis, CMV retinitis in patients with AIDS, or acyclovir-resistant mucocutaneous HSV and VZV infection in an immunocompromised host. So, foscarnet is typically, as I have seen it in practice, I've seen it more with the acyclovir-resistant lesions, but it does have the indication to be used in CMV retinitis in patients with AIDS. It has serious concerns. It can kill your kidneys. It can cause electrolyte and mineral imbalances, can be known to cause seizures, blood disorders, the bone marrow suppression, and QT prolongation and associated dysrhythmias. This is a drug that you give in the hospital and typically in an ICU with very close monitoring. Renal injury is the most common dose-limiting toxicity. You'll see a rapid rise in the creatinine. Most patients will develop some degree of renal impairment to some degree, but certainly if they already had underlying renal disease, this could be catastrophic. Renal injury occurs most often during the second week of therapy. Prehydration with IV saline may reduce this risk, and you have to monitor things closely. Surprise, surprise, it has a black box warning. The black boxes for renal impairment, seizures are the two that are mentioned. So it can cause low calcium, low potassium, low magnesium, and low phosphate. You can actually have normal levels of serum calcium to start with, and then you give it, and it causes hypokalemia or hypocalcemia. So they have to be educated on that. They have to know paresthesias, numbness in your extremities, perioral tingling should be immediately reported. Also, tetany or seizures, those kind of things. They need to have frequent metabolic panels that are monitoring for all these electrolytes and minerals. It also causes common reaction, and up to 50% of the patients will get something like fever, nausea, anemia, diarrhea, vomiting, headache, fatigue, tremor, irritability, right? So commonly people don't feel very good on this drug either. For monitoring of the foscarnet, you would need to be CBC, metabolic panels, and EKGs because of the QT issues as well. Okay, yay, so much fun. Drugs for hepatitis C. Hepatitis is viral hepatitis is the most common liver disorder in America. I still have to always read up on the viral hepatitis is hepatitis B, hepatitis C, antigens, all those things. It's like it won't stick in my brain. I review it all the time. So there's the different causes of acute hepatitis, and then there's different kinds of acute hepatitis. We have 6 versions: A, B, C, D, and E, and G. Only B, and C, and D cause chronic hepatitis, though. So those are the ones that tend to be treated a little more aggressively or urgently because that can lead to ongoing chronic liver problems. Acute hepatitis, by definition, will last for 6 months or less, and it's characterized by liver inflammation, jaundice, and elevation of serum ALT. In most cases, acute hepatitis does resolve spontaneously, so you don't always need intervention, but chronic hepatitis can lead to cirrhosis, hepatocellular carcinoma, or life-threatening liver failure. Most cases, 90% of chronic hepatitis are caused by either B, HBV, or C, HCV. So that's where the book tends to focus on. Drugs for hepatitis C. Transmission to obtain, to get hepatitis C, it's usually through exchange of blood, by injection being the most common, or sexual intercourse with an infected partner. Pregnant women who are infected can transfer or hepatitis C to their children. If you acquire hepatitis C, 75 to 85% develop active infection causing the symptoms that you see: jaundice, nausea, abdominal pain, myalgias, arthralgias. However, most people with chronic hepatitis C have no symptoms, so they're unaware that they are infected. Therefore, most are unaware that they're transmitting the infection. Chronic hepatitis C infection undergoes slow progression, and in some people eventually can cause liver failure, cancer, and death. So you could be positive for a carrier of hepatitis C for many, many years until it finally causes chronic infection and can lead to your death. It is important to note, though, that not all hepatitis C viruses are the same. They have their different genotypes, and then they have their different subtypes. Okay. In the US, 75% of hepatitis C is caused by a specific genotype 1, which unfortunately is less responsive than some of the other genotypes. This is a growing and evolving set of drugs that people are developing, and now we do have a lot better choices even just in the last few years for treatment of hepatitis C, and people tolerate them better and appear to do better with those. The goal of our therapy for the hepatitis C is to actually eradicate the hepatitis C virus RNA, which is predicted by attaining a sustained virologic response defined as undetectable RNA level 12 weeks following the completion of therapy. So they call that the sustained virologic response, or oftentimes is abbreviated as SVR. You may see this in practice. So I am pointing that out even though the book doesn't talk about it quite as much. We can get a sustained virologic response with 97 to 100% cases when you're being treated for the HCV. So it has a pretty good prognosis, and it can actually cure the HCV infection. So after you get your sustained virologic response with direct acting antiviral DAA regimens as well as interferon-based regimens. So once you use those two and you get to the sustained virologic response, that has been associated with decrease in all-cause mortality, decreased liver death, decreased need for liver transplantation, and decreased rates of hepatocellular carcinoma. So it has really good evidence to say that we should treat the hepatitis C and people can do really well. All patients with virologic evidence of the HCV chronic infection should be treated. So that means, to be defined as chronic, you should have a detectable hepatitis C viral load for over a 6-month period, and that's defining that you're chronically infected with the hepatitis. It's really awesome because when we started to introduce these drugs that are the DAA drugs, which is the direct acting antiviral drugs, right? So once the DAAs came onto the market, these drugs specifically target the non-structural protein of your hepatitis C and thus disrupt their replication and infection. And that really has revolutionized treatment for hepatitis C. It's highly effective, it's very well tolerated, and all of the oral regimens are the treatment of choice for the vast majority of patients with hepatitis C infection. When you go to your book and you're reading this section about these drugs, they talk about the DAAs, that we have four categories of these. So we have protease inhibitors, which are PIs, which is cimeprevir. We have NS5A inhibitors, which is declatasphere. Oh my gosh, you guys, I'm telling you, these drugs are going to be the end of me. And then the NSB5 nucleoside polymerase inhibitors, which are the NPIs, which then are going to be the sofosbuvir. And then we talk about the NNPIs as well. They're all used in kind of combination therapy, and we've learned that this works really well. Your book gives you a lovely little figure 80.1, as seen on your screen there, that talks about when you have hepatitis C and without cirrhosis, and then what particular genotype you have, talks about then the algorithm that you could follow. So we know a lot about hepatitis C now, and it can be very effective treatment. It often is effective treatment, and we can get people to be cured now from hepatitis C. 25 years ago, that was not the case. If you got diagnosed with hepatitis C, it was almost like a death sentence. People did very poorly with it. These are things that are typically managed by specialty clinics, infectious disease or hepatology, those kind of things. This isn't something that you're going to necessarily quote unquote manage like in a walk-in clinic or if you're in an ER, but it is important to understand the kind of the idea of how these drugs work, what they're used for, the side effects, etc. So then the book kind of breaks these down into the different combinations. What I want you to understand about hepatitis C that I think is what you need to know and what we want you to focus on and what's important is the things I just talked about. I am not worried that you guys memorize the different genotypes. You don't have to worry about all the different protease inhibitors versus NS5A inhibitor versus others. I'm not going to get that in depth on your test. There's just so much to know in these chapters. I do want you to read through the rest of this to see what the black box warnings are, to have that understanding. But really what I need you to know is that patients are on these drugs for HC or hepatitis C viral infection. We have drugs to treat them, and you're going to have resources to use to look up what the contraindications are for, etc. The big thing that I would review is what we've already talked about, and then go ahead and review the patient-centered care across the lifespan. That tells us again about pregnancy and breastfeeding. Okay, so that goes down through the end of the book when it's talking so that's hepatitis B or C. Moving on to hepatitis B, it's important to distinguish there's a difference between hepatitis B and hepatitis C. It's been a lot more, or it's been more, my gosh, there's less prevalence of hepatitis B because we do also now have vaccines against it. It's primarily transmitted through the exchange of blood or semen. So as healthcare workers, we usually all get our hepatitis B vaccines because of our risk of a bloodborne pathogen. If you have an exposure to hepatitis B, 45 to 60% develop acute hepatitis. So acute infection usually leads to the viral clearance by the immune system. So only 3 to 5% if you get infected will lead to chronic infection. However, if you are unlucky enough to get chronic hepatitis from the hepatitis B, it can lead to cirrhosis and death, as well as hepatocellular carcinoma. So the best strategy for hepatitis B prevention is prevention. All children should receive hepatitis B vaccine before entering school. What I'd like for you to know is that there's two classes of drugs for hepatitis B, the interferon alpha and then these nucleoside analogs. So they typically need these drugs for the treatment, and they have to have a prolonged treatment because there's a high rate of relapse after cessation of the treatment. So it can become very time consuming and very expensive to be on these drugs for months and months. They only typically will recommend treatment if you're exposed, if you're considered high risk, or if you have some of the other indications for that. Of the interferon drugs, they can be broken down into conventional versus long-acting. So if you have alpha interferons, they can be conventional or long-acting. The conventional preparation is interferon alpha 2B. It has a shorter half-life, so they get that drug 3 times a week. But in contrast, your long-acting, which is PEG interferon alpha 2A, is just once a week. So you may see patients getting this in a different, you may meet somebody who says, my drug I just take once a week. Someone says their drug is just taken 3 times a week. It depends on which drug you pick. thing to remember about the interferons is that all the formulations of interferon alpha, whether it's conventional or long-acting, have the risk for life-threatening adverse effects, and it has a black box warning that can cause autoimmune, infectious, and ischemic conditions, as well as serious neuropsychiatric conditions. So I do want you to know that interferon A, both versions, short-acting or conventional, and then long-acting, can have a black box warning to have serious life-threatening conditions. But the most common and typical one is that they sometimes get a flu-like syndrome, like fever, fatigue, myalgias, headache, chills, about 50% of people. So those symptoms do tend to diminish over time, which is great. And sometimes prophylactically treating with Tylenol can help. Interferon also and frequently causes what they call neuropsychiatric effects like depression and suicidality. The risk for depression is increased by larger doses and prolonged treatment. So sometimes people need an antidepressant because they have that risk. If you're on prolonged and high doses of the interferon, you can have fatigue, thyroid dysfunction, heart damage, bone marrow suppression, or it can also cause alopecia, loss of your hair, and those typical GI side effects. If you already have an autoimmune condition and you're given the interferon, it can induce or exacerbate your disease state, such as thyroiditis, or reactivate chronic hepatitis. Wouldn't that be lovely? So just to know, the interferons are one of the classes of drugs you need to have knowledge of for hepatitis B. They can be given kind of a shorter acting or a longer acting, but they can both carry the same significant black box warning and life-threatening side effects. And then that's a weird drug also, and it's good to know that they can cause like depression or other neuropsychiatric conditions. As far as the nucleoside analogs go, what I really would like you to know is that you can look it up in your book and see which nucleoside analogs are there for hepatitis B. Because again, we can really go into the weeds here about all of these different drugs, but it gets to be a lot by this point in this whole unit. So I want to kind of trim some stuff down, and I don't want you to worry so much about remembering each of the different drugs of the nucleoside analogs. Next, we go to drugs for influenza. We know that influenza is a serious respiratory tract infection that constitutes a major cause of morbidity and mortality worldwide. We all remember that we've had big flus that have wiped out large portions of people and leads to significant morbidity. There's like 300 to 500,000 Americans are hospitalized with influenza every year. And it can kill people. In my career, which I haven't been around forever, but pushing 2 decades, I've seen some pretty strange influenzas, and by strange I mean it has knocked down some young healthy men that were athletes. I mean, I've seen the flu. I have a healthy respect for the flu. Am I afraid of the flu? No. I have a healthy respect for it though. I recognize that that's something I have to keep in my back pocket as the differential diagnosis, and it's not completely unheard of to have someone get really, really sick just from influenza. So as a practitioner, when you guys are thinking about that, the reason I'm sharing that with you is I want you guys to have that same respect for influenza. Again, crap happens and people get sick, but I don't want you to treat like, oh, people get the flu, no big whoopee, right? I want you to have that respect that in your differentials of what could really just get somebody really sickly with respiratory failure and death is something as quote unquote simple as influenza A, influenza B. So it's worth knowing how we would treat this and what we would do with that. We know that we have influenza A, influenza B. Type A causes far more infections than type B. According to Laney's in your book, it's 96% of people will be type A and only 4% will be type B. And then they break that down into the 2 different subclassifications based on surface antigens. You don't need to know that. But that is where then we get H1N1, H3N2, some of those new fancy words that we get with that, because those are the specific types of the hemaagglutinin that they carry. So that on the surface of the virus itself, those different subtypes that you can get. All viral strains undergo constant evolution. So as a result, strains of H1N1 in circulation this year are going to be different than H1N1 next year. That's why the flu vaccine is given every year, and that you have to kind of wait for it to be developed and what they're anticipating to cover the next year. That's why. We know that the flu is highly contagious, and it's spread by aerosolized droplets that come from coughing or sneezing. It enters your body through the mucous membranes of your nose, mouth, or eyes, and the replication takes place in the respiratory tract. Your symptoms typically begin within 2 to 5 days after exposure and last for 5 to 6 days typically. Influenza, or think of fever, cough, chills, sore throat, headache, myalgias, muscle pain. For typical patients, so an immunocompetent patient, the infection results in 5 to 6 days of feeling pretty down and out. And sometimes of those days, maybe 3 or 4, you're actually like in the bed, you can hardly move. Influenza is best managed by vaccination and then also with drugs as a secondary. So annual vaccination is the best protection against the flu. Because influenza viruses are constantly evolving, our vaccines have to constantly change as well. Each year, manufacturers produce a new vaccine directed against the 3, so trivalent, or 4 quadrivalent strains of influenza virus deemed most likely by the CDC, FDA, and WHO. 3 basic kinds of vaccine are available. So you have your inactivated influenza vaccine, recombinant hemagglutinin vaccine, and your live attenuated influenza vaccine. So your inactivated flu vaccine and your recombinant hemagglutinin vaccine are administered by your IM injection. We do have one option of intradermal. And then your live attenuated virus is done by your intranasal spray. Table 80.2 breaks this down very nicely. Remember, you can't get it if you're allergic to eggs because the source is an egg-grown virus. There's some differences about what dose you can get at what age. Even down to 6 months can get the flu vaccine. The live attenuated one, which is FluMist, if you've heard of that, is given to people between the ages of 2 and 49. We do have some options to be better for people with egg allergy, and one of them is the Flucelvax, which is grown in dog kidney cells. But the CDC does not always consider that truly egg-free. So that's something you'd have to consider with a specialty person. Okay, efficacy. Each year the CDC conducts vaccine effectiveness studies, and they feel that the efficacy of our flu vaccine ebbs and flows. Sometimes they're better than others because it's kind of a crapshoot hoping you hit the bullseye. Significant adverse effects from the vaccine are rare. Okay, the inactivated influenza vaccine that's given intramuscularly or intradermal. If you've never been vaccinated before, they say you're more likely to get the fever, malaise, or myalgias. So they're saying if you're getting it every year, most people stop having those kind of reactions. Influenza vaccination may carry a very small risk for Guillain-Barré syndrome, which is a severe paralytic illness. So if there is a risk, it's very small. It's only about 1 to 2 cases per million of vaccine recipients. So according to our book and according to the CDC, you would be able to educate your patients that the risk is very small and should not preclude them from getting their influenza vaccine. The live attenuated influenza vaccine has been given to millions of people since 2003, and the serious adverse effects are rare, but you can get nasal congestion with rhinorrhea, lethargy, headache, sore throat, or decreased appetite. People with an acute febrile illness should defer vaccination until their symptoms abate. If you have like a common cold with or without fever, that doesn't mean you cannot get the vaccination. Previously, there was that great concern we kind of already talked about with the hypersensitivity to eggs. Although FDA labeling continues to warn against such vaccines to people with severe egg allergies, persons with a history of egg allergy may receive appropriate flu vaccines according to some of the latest reports. Who should be vaccinated? We kind of probably already knew this, but let's talk about it again. It's recommended for everyone, but especially if you're at high risk or you live with someone who's at high risk. So children under 5, definitely children under 2, 18 years or older that are on long-term aspirin therapy. If you're pregnant, if you're over 65, if you're obese, living in a nursing home, Native Americans, people who are already immunocompromised or chronic conditions, and they list them all in your book. Remember, if you are immunocompromised or at risk for those things like we talked about, they should only get the inactivated virus. It's the only way it should be studied, or it's the only way that those people have ever been given something that's been studied. Pregnant women also should be given the inactivated vaccine. There's very few people that should not and cannot get the flu vaccine, and those are severe allergic reaction to previous vaccines of the flu, or if you've had Guillain-Barré syndrome within 6 weeks following that administration of something before. So there's very few reasons why someone really should not get the vaccine. You hear about the flu season, so we try to give wherever your region is of your flu over past years. So some people get it as early as September. Some people don't get their flu vaccines till July. It's based on trying to capture the best time to give it based on your history of your region. All right, so treatments of the flu. So we always want to prevent it, but then if you get it and we want to try to treat it, we have a couple of options. The adamantanes, which is amantadine, which is Symmetrol, and the rimantadine, which is Flumidine, were the first influenza drugs available. They're on the market, but most strains of influenza A are resistant. Well, isn't that lovely? Because influenza A is much more common than B. But all strains of influenza B are resistant, so we don't really use these drugs. So I love that they put it in there, but you may see it as listed as a potential in the past. Nowadays, we use the neuraminidase inhibitors. I cannot say these drugs, which are oseltamivir, which is Tamiflu, peramivir, and zanamivir. The peramivir is Rapivab, is IV. Both oseltamivir and Zanam, the Z1, are approved for influenza prophylaxis and treatment. They do not work prophylactically the same as a vaccine, so you don't want to give these instead of the vaccine. It takes about 2 weeks after vaccination for antibodies to develop against the influenza virus. When used any of these drugs, like Tamiflu for treatment, your dosing must begin early, no later than 2 days after symptom onset, and preferably much sooner, because the benefits decline greatly when your treatment's delayed. When treatment is started within 12 hours, it's reducing your symptoms by 3 days. If it's started within 24 hours, it's reducing your symptoms by 2 days. But if you wait until 36 hours, symptom duration is only reduced by 29 hours. So in the real world, most patients don't get it fast enough, therefore it probably doesn't have great value. For Tamiflu, it derives from inhibiting the neuraminidase replication, and so the newly formed viral particles are unable to bud off and cannot replicate. The Tamiflu is effective against most strains of A and B, so that's a good thing. 80.13 table kind of shows you the peak, the timing, the metabolism of those drugs. It has few side effects, Tamiflu, but the most common could be headache, nausea, or vomiting. So if you already kind of have a headache and nausea from the influenza, and then I give you Tamiflu, I may not be doing you many favors. People think that you should give it with food, and that could help. In theory, Tamiflu can blunt your response to your live attenuated virus, so there may be some dose adjustments for that. Candidates for prophylactic therapy, so you give it before you're flu positive, are for family members of someone with the flu and residents of a nursing home. So we do this all the time. If you're in the hospital or long-term care facilities, you're going to see that if you've had a positive flu, everybody on that wing or unit is going to get a 5-day course of Tamiflu. And that is pretty well accepted amongst long-term care communities. And I've never actually reviewed that data myself to say, but I can tell you it's what's recommended and what is done. The other drug to point out is this zanamivir, which is Relenza. That's oral inhalation for treatment of uncomplicated flu for people that are 7 and older. It's pretty well tolerated, but not something you'd want to give to someone who has asthma or reactive airway disease. I don't, I'm sorry. Yes, there is more. The endonuclease inhibitors are the newest drugs on the market for treatment of influenza. Those are like Exofluza is one of them as well. So I just want you to hear it and know that it is a newer drug that is out there. It's a pro drug, and it works a little bit differently than the Tamiflu. That's what I want you to know. Next thing is drugs for RSV. Respiratory syncytial virus is something we oftentimes think in newborns and little kids, right? But this is a virus that can affect also the elderly. Anybody can get RSV, but it's really bad on children and infants, and it's particularly troublesome for elderly people with COPD or asthma. So there are some options of what we can do for RSV prophylaxis. So the drug is Synagis, which is palivizumab. I've only heard it as Synagis. It's a monoclonal antibody that's specific for preventing RSV infection in premature infants and young children with chronic lung disease. The antibody of that drug binds to the surface protein on the RSV and thereby prevents replication. It has shown to reduce rates of hospitalization in these young children. So sometimes, like if you were a NICU baby and you're getting released and going out into the community during RSV season, which is like December through March, people will just prophylactically be treated with this drug, which is pretty expensive as well. But these little ones will get this drug prophylactically to prevent complications from RSV.
And it looks like Ryan Stubbe and Drake Eastman.